questions on hyperextension or angular limb deformities before we go on to hyperflexion? So similar to the angular limb deformities, they can happen in a couple of different ways. One of them tends to be around birth time, and one of them is acquired later on. So congenital basically means they come out that way when they're born. Reasons for that may be intrauterine malposition. Some of these are theoretical because a lot of the times we don't really know. Diseases caused by mares, acquired by mare during pregnancy, such as influenza or teratogens, with examples being low wheat or hybrid Sudan. Acquired, kind of like we talked about with the angular limbs, nutrition, more often excess energy. Okay? So the colt, this farmer's really proud of, he feeds it well, it's growing really fast. Those are going to be the ones that tend to have a problem. Because remember we talked about, there's two columns. There's the bone column and there's the tendon and ligament column. The really fast-growing colt may be growing those bones faster than the tendons and ligaments can catch up. Other things that can happen are long periods of not bearing weight, such as an injury for some other reason. And I give this example. 2 days before I graduated vet school, I was in a car wreck and fractured my patella. I was in like a big full-length splint for a while. And when I came out of that a couple months later, I couldn't bend my leg past like this, So, and it wasn't because of the bones, it was because my patella ligament basically just contracted because it hadn't been moving. So it took me like 6 months to get that flexibility back. But that's kind of what can happen if you just don't move things, they lose the elasticity. And then any painful condition causing muscle contracture itself. So usually when we're talking about hyperflexion, we're referring to the forelimbs. Occasionally you can see something in the tarsus. That would be a congenital thing when the foal comes out usually, but it's much more rare. So usually we talk about the forelimbs. And the most common site is probably going to be down here in the foot at the distal interphalangeal joint. We'll talk about that first. And then other things in the fetlock. Here's a hyperflexion fetlock. And then here's one at the carcass. Really, really have to go back to the picture of normal in order to determine what's abnormal. So when I give you an image like this, you're going to say, well, is the fetlock in a normal angle? Yeah, that's what it should look like. But from here down, they're supposed to be in a straight line, right? So I've got this line, and I'm falling off the cliff here. Okay, you do that anytime you you see one of these pictures. So this guy right here, these are pretty much in a straight line, right? But that fetlock that's supposed to have a good amount of normal, like hyperextension, kind of a normal hyperextension is kind of a oxymoron, but you get my idea. So he's standing up straighter here in the fetlock than he should be. So you have to think back to where normal is. All right, so diagnosing these guys, the position of the limb, question?
For the fetlock, would it be more, for that working, would it be stronger confirmation if you like radiograph?
Yeah.
To see that?
Let's talk about that. Here. Got it. So position of the limb, just what you're seeing there, first of all, and then from there, how do we confirm what we're seeing? How do we know exactly what's causing this? A couple different ways, palpating those tendons. If you think back to those anatomy images I showed you, there's a lot of flexor tendons and other extensors and things like that in ligaments. Go through individually. Do you guys remember in lab, I think most of you tried to do this, picked up the leg and said, okay, this is the superficial digital flexor tendon. I got my fingers directly on that. Then I squish a little further inwards, and that's my digital flexor tendon. So you can separate out all those structures. Okay, with your fingers, you just have to think through, this is the anatomy I remember in class, and I'm going to feel for that individually. So which one of those is tight? If you flex that leg and the digital flexor tendon is still tight, that's your indicator of what's going on. But then also radiographs can help you be a little bit more correct. So this is the first one we talked about, probably the most common one we'll see, and that's a flexural deformity at the level of the distal interphalangeal joint. So remember how we try not to say contracted tendons, right? So really what we should be calling these things are, it is a flexural deformity at the level of such and such joint, okay, for whatever reason. So here is a flexural deformity at the level of that joint. The common term for this is clubfoot. You will see these to greater or lesser degrees. Sometimes in riding horses that they have you know, they're going around being ridden and they have a mild club foot, nothing that's gonna, you know, give them any severe issues, until maybe later on in life. But it's relatively common to see this in a horse that's just out there, the owner might not even know it. Alright, so what club foot looks like, and here are varying examples of it. Let's take this middle one to begin with. You have a steep dorsal hoof wall, a short toe, because it's kind of been blunted off, because he's riding right on it. And the fetlock may actually hyperextend to make up for the weird angles over here. So don't make too much about that, but like just remember this fetlock, because of the weird angles, may actually be even a little bit more extended than usual. You can see on this image here in the radiograph, you have a straight line coming down here, so a straight line through the long pastern and short pastern bones, and then an abrupt change in angulation, okay, with the dorsal aspect of the coffin bone and the dorsal aspect of the hoof going together. So here's a lesser example of it. So I've got a straight line here. Let's call this one mostly normal. So I've got a straight line here that comes right through the long pastern and short pastern, and then you can imagine it kind of probably goes right down through that coffin bone. Versus this one over here, you've got a straight line, and then I want you to think past the fact that it's flared here. Go down the middle, straight line, and then goes off the cliff a little bit. Not as bad as the middle guy, but definitely you have a change in angle right here, okay? Now, they can have this little bit of flaring on their toe just due to the fact that they're putting pressure on the very toe part, and sometimes the hoof will grow that way. But you've got to look at the angle, almost like at the coronary band here, and ignore this part down here to get the sense of what's really going on. Look at the difference in the heel height. Look at this really high heel on this left front foot and the low heel on the right front foot. All right, that's actually quite common to have one high, one low. So this is your club foot here on the left front, and this is we'll just call it a normal or even a little bit on the low side. Right. All right, so what happens here is a restriction of the deep flexor tendon relative to the bony column. If you have a pure club foot with nothing else, sometimes you get a little bit of more than one thing. Let's just think through the simple stuff first. So if you have your deep flexor tendon, it's relatively too short. Where is it attached? Where on P3? At the back, right here. Not in the front, it's not on the bottom. It's like right at the back here. It's kind of grabbing on, and if it's too short, it's pulling that bone with it. There's nothing else that attaches to P3, and that deep flexor tendon doesn't attach anywhere else. So remember, that's going to directly impact the direction of that P3. So how do we know this is not laminitis? It's weird, right? I mean, you got like your line here, and then it looks like it rotates. What's that?
From P3 to the wall is not.
Yeah, good. So basically you have what looks like rotation, quote unquote, but you're still parallel between the dorsal hoof wall and the dorsal aspect of that coffin bone. The laminator is still tight. It brought the whole foot with it. All right. If it was laminitis, what would it look like? It would be, you know, you can imagine the hoof wall would continue to come down this way, and you get your, instead of parallel, you'd be, you know, have a triangle there instead. So classification for these club foots, stage 1 is lesser affected. The angle between the dorsal hoof wall and the sole is less than 90 degrees. So, you know, this right here, this line here to that line about less than 90 degrees. If you have a stage 2, that's when they're really severe. You can see in this radiograph, it passes vertical. So it's now like this line to that line is greater than 90 degrees. So just think about stage 1 is lesser affected than stage 2 is more affected. Yes, correct. Yeah. Now, one thing you occasionally will see, don't be distracted by this. See this flare at the bottom there? It's the same as like that right there. That's just a factor of the fact that, you know, if you don't trim that little flare off, it tends to just push out, like the white line gets stretched a little bit. Don't consider that, like, you know, that's not part of the whole measurement, right? So you're going to be looking basically from like where you've got the end of the coffin bone, where you've got the top of the coffin bone. Those areas are still there. So that club foot is what? What tendon did we talk about? Club foot? Deep digital flexor tendon. If we have a pure club foot, we just say it's DDFT, okay? Now moving up, let's look at these. So this guy right here, so the angle between the dorsal hoof wall and the pastern, is that normal? Is that straight? No. So look, I'm drawing like, you see my little marker here on the left-hand picture? So right here, or right there. That looks pretty straight, as opposed to, you know, look at that guy. I mean, we're changing direction down here, right? Okay, so this one does not change direction down there. This would be okay if he didn't have this huge knuckling over here at the fetlock. Okay, so here's a more affected one. In the middle picture, the right front, much more affected. You can imagine this is a fairly straight line here, but the abnormal angle is here at the fetlock. And this one is lesser affected. So straight line down here, the hoof pastern. And then you don't have as bad a knuckling over. You're more like you're straight where you shouldn't be straight, right? So remember, he's supposed to have an angle here at the fetlock, like breaking back almost. And these guys are straight or breaking forward. So what this is, it doesn't really have a cute name like club foot. I call it knuckling over sometimes, but it really doesn't have like a actual name. So it's a flexural deformity at the level of the metacarpal phalangeal or metatarsophalangeal joint. So flexural deformity at the level of that long. So we would have this straight metacarpal phalangeal angle, or in a greater extent, they actually knuckle over. So where does the superficial digital flexor tendon attach? P2 and P1. So you can imagine the deep digital flexor tendon is normal because it hasn't pulled the hoof backwards. But we have something that attaches like here and here, pulling, which affects the fetlock. So SDFT, like you guys said, attaches kind of like at the back and the sides of P1 and P2. All comes back to anatomy, right? All right, so practice. Which is normal. First one. Left. Is that your first one? Go left. Okay, correct. You got to, your normal hyperextension, quote unquote, angle at the fetlock, and then the straight line through these things. What's this here? Yeah, club foot, hyperflexion at the level of the coffin joint, at the DIP joint. Yes, good. So this is severe, right? I mean, so I guess maybe that looks like straight up and down. So it'd be up to you whether you call that stage 1 or stage 2, but it's pretty severe. I'd probably say that's a stage 2. And how about this guy right here? At the level of the, yeah, affecting what tendon? If it was pure, not hard, right? Okay, so non-surgical treatment for whatever category you're talking about. Restricted exercise, don't completely eliminate them, because remember what happened to my leg when I completely eliminated exercise for a couple months. I had zero flexibility afterwards. So you want them to not be running around, not being, ridden and jumped and showed and stuff like that. Not at that age, honestly. But you don't want to completely take away exercise. Analgesics, because it does sometimes hurt to be in that position, and sometimes the more pain they are, the more they restrict themselves. Toe extensions, like this little thing here, and shortening the heel. Kind of the opposite of the hyperextension. Remember, for the hyperextension babies, you put those heel extensions on, and then that stops them from, kind of going too far over. This is just the opposite. Splints, casts, heavy bandage. This is I think it's called a dynasplint. Before I get that picture right, it's the dynasplint. So this thing, you can almost ratchet it to like a certain degree. So as you put this thing on, at the beginning, you just kind of set it for a little bit of tension, and as the horse gets better, you can set it for a little bit more. So that's one option. Remember your sores, always with the babies, even adults, be very careful with that. And then if you think nutrition is a part of it, you're going to reduce their energy intake and balance their vitamin.
I'm sorry, can we go back to that which is normal That third one?
That one?
Yes, what did we say?
This one right here?
Yes.
So this is a restriction at the level of the, it's a flexural deformity at the level of the fetlock. So it would be a superficial digital flexor tendon restriction.
Thank you.
Okay. Another type of non-surgical treatment, oxytocin recycling, the antibiotic, same antibiotic you use for bacterial infection. So we don't exactly know the mechanism of action for this, but what's thought to be the case is that it inhibits collagen contraction by the fibroblasts, decreases MMP1, metalloproteinase 1, I think. So inhibiting the traction shortening of this collagen fibers. This is something you would do. New baby, it's come out, the owner calls you, they're like, oh, my marifold, and it's all contracted or whatever. So you're coming out to see this baby, maybe a week old, at the stretch, a couple weeks old or something like that. This is not something to give the 6-month-old. This is not something to give the yearling, that's developed some sort of injury and that's why this is. This is not up here for like your yearling, 2-year-old sort of thing. This is like new baby treatment. Okay, it doesn't really work in nipple. So you give your dose, just one dose. Wait a couple days, see what happens. If you think it's helping, give another dose. Maybe you can do it a couple more times. But really it's just, you give it a few times, and if it's not working, it's not. And if it works, you can try a couple more times, then you've probably done. Same cautions with giving Oxytet that you would for any case. Remember the babies especially, be careful with their kidneys and things like that. Yeah.
Are there any concerns about when the animal's older?
With the Oxytet or having a
With the ox?
no. I mean, as long as you don't do anything that affects the horse systemically, you're just giving it a couple times. Chelates calcium, so it's really more of like a immediate kidney or heart kind of risk, but as long as you're using it carefully, it's pretty comfortable. So recheck them frequently. These are ones that it's nice to have in the hospital, or have a client you really trust and you're going to go back and see a couple times, because you want to make sure you get on this, because it sets the horse up for either success or failure athletically later on. So surgical treatment will either be for the severely affected foals, remember that carpus or some of those severe club feet I showed you. Those are not going to respond to stall rest and splinting and things like that. So you have to do something more dramatic for them. Or those that you've tried the Oxytet on and you really just not getting it. And remember, the procedure choice depends on what you think is restricted. So we'll talk about that again. The way I'm teaching it here is like, oh, this is a clubfoot or this is a fetlock deformity. Remember, it can be both. So if you have both, you may be working on both tendons at the same time. So just a little reminder here of our anatomy. So number 1 is the superficial digital flexor tendon. 2 is the deep digital flexor tendon. Now let's talk about 3. Yeah, good. So check